Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Yeah, we can go ahead, Sujata ma'am.
Yeah, okay, thank you. Good morning, all. This is Sujata. I'm a deputy editor at the Hindu reporting section. Welcome all to this section of the webinar. Today's webinar is on how hearing impairment is treated at childbirth early so that children can actually develop well as normal children. We have with us a set of eminent panelists. I'll introduce each one to you. Dr. Manusruth is a consultant ENT and cochlear implant surgeon at Yashoda Hospital, Somajiguda, Hyderabad. He has 9 years of experience. He graduated from Gandhi Medical College, Hyderabad, and did his master's in ENT from Kasturba Medical College, Manipal. He has completed advanced training in cochlear implantation and ear surgery and is one of India's first and youngest fellowship-trained cochlear implant surgeons. He did his fellowship from Christian Medical College, Vellore. He is also a trainer for temporal bone workshops and has been a faculty member in many state and national conferences. Welcome, Doctor. Dr. Vikram is a consultant, ENT and rhinologist, skull-based surgeon he's also a skull-based surgeon at Naruvi Hospital, Vellore, with 7 years experience. He graduated from Jawahar Nehru Medical College, Belgaum. After MBBS, he was selected for the Armed Forces Medical Corps, wherein he served for 6 years, during which time he qualified to be part of elite special forces of Indian Army. He did his master's in ENT from Command Hospital, Air Force, Bangalore. He has completed advanced training in rhinology and skull base for Christian Medical College, Vellore. Dr. Nadia Faisal is an otorhinolaryngologist and is the head of neck surgery. And works in the head and neck surgery department. Dr. Faisal is a consultant ENT surgeon. She completed her master's in ENT from Kasturba Medical College, Manipal. She has 7 years experience in the field and currently works at Naruvi Hospital, Vellore. Welcome, doctors.
Thank you, ma'am.
Welcome, sir. So would Dr. Manusruth like to start the proceeding?
I think Nadia would start the...
Nadia. Oh, Dr. Nadia, yes. Dr. Nadia.
Good morning, one and all. So first and foremost, I would like to thank Hindu with their wellness series, as well as Naruvi Hospitals for organizing this platform for us to speak on a major issue which concerns newborns. It is a great pride actually to be live here too. So shall I share my screen now?
Sure, ma'am.
I hope I'm audible and my screen is visible.
Yes, ma'am, please go ahead.
Sure. So I would like to touch upon some areas regarding how to deal with newborns and taking care of their hearing at an early stage so that we detect any issues early. So why are we discussing this in the first place today? It is really scary to know that around 2 to 5 newborns, children born, are out of 1,000 are having some sort of a hearing disability. Coming to developing countries like ours, it comes up to 10 per 1,000 live births. In simple words, 1 out of every 100 babies born have some hearing disability. So, and it is a leading cause of disability on a global scale as well, because hearing, as we all know, is very essential for overall development of an individual at multiple levels, for psychosocial development, for general emotional well-being, academics, learning, and even cognitive development is based on hearing, vision, and a lot of other things. And it's very sad to know that initially it mostly goes unnoticed, and around half of these babies have absolutely no risk factors that we have to take cues with. So because it develops, it causes problems in development on an all-round scale, it affects the quality of life eventually for the child. So what we are aiming at is prompt and early identification so that we can intervene and help the child not step back. So routine causes of which 30% is preventable. So we're aiming at catching them early so that we don't have long-term impacts. Usually, screen. So earlier, the protocol was to screen babies who had risk factors, like, for example, babies born to parents who are consanguineous, that is related parents from the same family, babies having somebody in the family who has a hearing loss, or babies when the mother was pregnant had some viral infection, or some syndromic babies, like commonly we see Down syndrome babies. All these babies are at a higher risk of having hearing loss, not necessarily to be. Other common causes are, some defects of the head and the ear region, like mild deformed or deformed pinna or the external ear. Babies who are born early, or premature babies, or having low birth weight, babies who had to be in ICU for a prolonged duration, at least more than 5 days, babies who had high bilirubin levels, that is jaundice in the initial stages of life, babies who had to take some medications for some conditions. They had infections like in the initial days of life. All these babies are at a higher risk or at hearing. But no, we're looking at universal newborn hearing screening. That is, every baby born is supposed to be screened for hearing. Ideally, within 24 hours of birth, as early as even 12 hours, we can screen babies, or at least before the baby goes home is what we are aiming at. Being a developing country, and almost a good percentage of our births happen still in the villages, and so at homes or birthing centers or even nursing homes, at least when the baby comes back for the first vaccination visit or a pediatric visit, the baby should be screened. So the recent consensus statement says that we have a goal of 1, 3, and 6 benchmarks. That is, at least by the first month, the baby is screened. And by 3rd month, if there is some suspicion, the baby is evaluated completely. And by 6 months, we intervene. Why 6 months? Because that is when the baby starts picking up cues from the environment, starts developing some sort of cognition, as well as language skills in the long run, which will translate into their development. Now, how do we go about this? So after the babies are born and the basic checkups are done, usually an audiometrist will examine the ears, the external ears, for anything obstructing the ear canal. And there are 2 basic tests which are very affordable, easy, quick, gives immediate results, and absolutely painless to the baby. So the tests are known as OAE, that is autoacoustic emission test, as well as ABR, auditory brain stem response test. How do we do it? It is the first test, which is an automated test. It's a small machine with a probe attached to it. So it's a tiny soft probe is placed into the ear of the baby. This is a baby who underwent this test 2 days back in our hospital. And a click is presented to the ear, and the ear responds back with some echoes, which is measured by the same probe. And the result is there in 20 seconds or so. The same thing is repeated on the other sides, and the results are expressed as either pass or refer. Pass means your baby almost has normal hearing levels. Refer means there could be some problem, so we need to repeat the tests. I think there's a video issue. I'll just show the video in the end so that parents have an idea regarding how safe and painless for the baby it is. if the baby fails this test, maybe at an interval of 2 to 4 weeks, we repeat it. If there is some different result which comes, then we have to do the next test, which is also an automated test. It's a non-invasive test. It's called ABR. So again, it is done by placing electrodes on the surface of the forehead. Behind the ear, there's a bone. So there are 3 electrodes which are placed on the surface of the baby's head. And again, sound clips are presented, and how the nerve responds to the sounds is depicted on the screen as pass or refer results. And depending on that, we can say whether the baby is needs further evaluation or is fine. So both these tests, what it requires is a relatively soundproof room, that because some external sounds may interfere with the test. Cost-wise, it's very cost-effective. The first test which I mentioned called OAE costs somewhere between 600 to 1,000 rupees maximum. It varies between hospitals. They're both sensitive, as in they can pick up mild hearing loss at an early level, and they're specific as well. The ABR test, which I mentioned, can even detect some nerve problems to the ear, which helps in hearing. So what I want to say is these tests are not diagnostic. They are just a screening pathway so that we can further evaluate if we find any abnormality. So what if the result is comes as refer? Parents need not worry. We have to repeat it, like I said, multiple times, probably at 2 to 4 week intervals. And even still, if there is a suspicion regarding the hearing, then we need to do the further evaluation. What if your baby didn't have a chance to get the screening done? Still, there are ways to find cues from the baby's development later in life at various levels, so that we can pick up if there is abnormality, if any. And what do we do about it? So my colleagues are going to talk about all these other aspects. Over to you, Dr. Vikram. Thank you. Excuse me, could I just share the video I was talking about? I don't know why it was not playing. I'll just finish that and... So that was the test. It's as simple and quick as that. The baby is quite relaxed. It is not having any sort of discomfort, and the results are immediately there on the screen. So this was a baby we had in our hospital just 2 days back. Thank you for patient listening.
Thank you, ma'am. I request Dr. Vikram to please make his presentation. Dr. Vikram.
Am I audible now, ma'am?
Yeah, you're audible. Yes, sir.
Good morning, everyone. Merry Christmas to all of you all who are attending this webinar today. So dealing with the topic of hearing loss and newborn, I'll be specifically talking about early signs of hearing loss. As my colleague, Dr. Nadia, pointed out, that many of the deliveries that happen may happen in houses or may happen in smaller hospitals, which may not have hearing screening methods employed in their hospitals. However, slowly we are growing towards universal neonatal hearing screening, wherein, as she pointed out, every child needs to be screened at least by the time it comes for its first vaccination. So I'll be speaking more about things that can be picked up at home. So just again re-emphasizing on the disease burden. If you look at India, it's roughly about 1.5 to 8.8 thousand live births that take place in India. So when a child is born, at home, when he is exposed to any kind of loud noise, for example, sudden sound of a pressure cooker or a mixer grinder, or any sound like a car honk, or especially nowadays firecrackers or anything. So any newborn child has a reflex which is called the startle reflex. It when it hears the sound, it spreads both its arms, and then it extends its legs, spreads out its legs, and then brings the arms back. This is called a startle reflex. And also, some of the kids, newborns, can cry. And so, this is something which is seen when the child is born to roughly about 3 to 4 months. And parents can easily notice whether the child is having this reflex or not. This reflex is kind of present universally in all the babies with good hearing. So coming to the next, when the child is born to roughly about 3 to 4 months, it starts recognizing the voices. It especially starts responding to mother's voice, either maintaining an eye contact or smiling, so nodding its head slightly on seeing its mother, on hearing the voice especially. So we need to take a look at all these events that take place. So from 4 months to 9 months, we can see that a child starts responding to toys that make sound. So especially when the sound is made behind the back of the baby, whether the child is turning, whether it's getting alert, these are the things that we need to be noticed by the caretakers. So again, from 4 months to 9 months, when we speak to a child, does it smile back? Does it have that expression on the face? Is it able to maintain eye contact? These are the important things. Once the child starts coming closer to 5 months or 6 months, there's something called as babbling. These babblings are sounds like ma, ba, da, and as the age grows, it's able to say mama, dada, and all this. So the hearing and the speech development are interlinked. So we need to see whether the baby is able to make these babbling sounds or not. As the child grows older, it starts understanding the hand motions when somebody is waving the bye-bye, or when it starts clapping when you act silly, or nodding its head by the time it comes closer to its first birthday. Using your voice to get attention. Actually, when a baby makes different kinds of noises for different kinds of needs, like if it needs any feed, or if the nappies needs to be changed, or if it needs to get the mother's attention. So every time sound made is different. And when you're talking to the child, whether it is being attentive or not, all these things need to be observed at home. By the time it's beyond 9 months, the child starts recognizing its name, which is very important, and whether the child is responding to the name call that is given by the caretakers. These are the things that needs to be observed. And beyond its first birthday, any child is able to usually point out to the common body parts, eyes, nose, ears, and all that. So it's able to show you when you ask, show me your ears, show me your eyes. It's able to easily point out. So if you can pick up these cues, whether the child is able to do all these things or not. I'm not saying specifically that if the child is not able to do this, the child has hearing loss, but you need to grow suspicious and understand that the child may need to be investigated, to be taken to the nearest hospital, shown to a ENT consultant to be further evaluated whether the child has hearing loss or not. And by the time it is close to its second birthday, the child is easily able to name few objects, commonly used objects at home, like a ball or a bat or a dog or a books, something like these common household items. Um, Closer to its second birthday, if you play any rhyme or you tell any story or any song, the child is attentive, it listens to it, or if it is playing from a different direction, it usually tries to turn towards that direction. So these are all the things that happen at home. And so the main importance of this is that if any child misses out on newborn hearing screening, and the caretakers need to be aware of these things, and early detection is important in hearing loss, because early intervention and early treatment is supposed to have the best results when done timely. Thank you.
Thank you, Dr. Vikram. That was quite interesting. And yes, the caretaker's role you've explained very clearly. Dr. Manasmrut, will you please start your presentation?
Yeah, thank you. Can you give me the access? Yeah. First of all, I would like to thank the Hindu and the Naruvi Hospital for inviting me as a panelist. And I would be speaking upon the management of hearing loss. As my other panelists have explained, how and when the hearing loss is identified. So one important thing is that early identification is the key in the management of hearing loss, because the more the delay happens, it becomes more difficult for the child to understand sound and eventually start speaking or have a clear speech later on in their life. So in a child with hearing loss, there are two ways in which it can be managed. For children who are newborns and who have been detected by 3 months or 6 months of age, they need to get a hearing aid to help improve their hearing. And hearing aids usually help by amplifying the sound and sending the sound through the ear canal, which hits the eardrum and then eventually activates the cochlea, which is the inner ear from which the signals reach the brain. So once the testing is done, it is important to identify what is the level of hearing loss. And if the child has got a severe or more than a severe hearing loss, that is more than 70 decibels, then hearing aids may not be of that much benefit and may eventually not lead to a very clear speech. But for younger children who have been detected before the age of 1 year, they need to be on hearing aids, even if it's a severe loss, because it helps in some kind of sound perception. And once they are at the age of 1 year, they are reassessed and then appropriate treatment like a cochlear implant can be done. So there is a misconception among parents or even caregivers that young children cannot be aided or a hearing aid cannot be put on them. But this is a misconception. And earlier the child gets a hearing aid, his brain gets activated and there is sound perception, which along with appropriate speech therapy can give good results. So how long can a child wait with hearing aids? So usually if it is a young child, the deadline is 1 year of age, and we see whether the child has developed age appropriate speech or not. And if that has not happened, then it is a time when we have to plan and start speaking to the parents regarding alternate options, which is a cochlear implant. So basically a cochlear implant is an electronic device and it does not work like a hearing aid, which is hearing aid just amplifies the sound. But a cochlear implant bypasses the entire hearing pathway, and it is a surgical procedure in which we put a device under the skin and an electrode which goes into the cochlea, which is the hearing organ. And there is a speech processor outside which connects with the internal processor with a magnet. And this eventually codes the speech and sends the signal to the internal processor with radio frequency signals, and which are converted to electrical signals which directly stimulate the hearing nerves. And this electrical stimulation is perceived as sound by the brain. So eventually we are actually bypassing the entire amplification route and directly stimulating the nerve. So children with more than 70 decibel hearing loss, severe hearing loss or profound hearing loss, and those children who are on hearing aids, but eventually their speech clarity is not good or they are not able to perceive well with the hearing aid as the age goes, such kids are candidates for cochlear implants. So this is how an implant looks like. This is the internal device which goes under the skin, and it is fairly not a very complicated surgery. It takes around 1.5 hours, and the child stays in the hospital only for 1 or 2 days. And after 3 weeks, once the wound has healed, the external processor is put, and this eventually activates, and the child starts hearing. And child also needs to undergo a speech therapy, which is also called auditory verbal therapy, in which the therapist helps the child to understand these signals which are received by the brain, and child eventually develops speech. And children who are implanted early, at the age of 1 year or less than 2 years, will eventually have speech clarity same as their peers, and it will be difficult to tell the difference between an implanted child and a normal child. But as the age progresses and the child is around 4 years or 5 years, child can be implanted, but the speech results are not that good, because the capacity of the brain to understand the signals becomes more difficult. So children with both sides hearing loss are the main target children for cochlear implants. And these children can receive a single implant or both implants depending upon the parents' wish. And children who are implanted both sides have better speech, and they can understand music better. So the higher modalities of sound and speech are perceived better by these children. Thank you. We are, I think, happy to take questions.
Thank you, Doctor. So there is actually a question here right in the beginning. I think it's for you, Dr. Manasumat, or any of you can answer this question. So an infant who is a year old and he has hearing loss, the baby has hearing loss, but the baby has been put on hearing aid and it keeps pulling off its hearing aid. So they want to know what to do. They want an advice for this situation and measures to prevent the child from pulling off its hearing aids. Is there something we can do about it?
I think we have to understand why the child is pulling off the hearing aid. So there could be a couple of reasons. Either the amplification is too high, so that means the child is perceiving the sound too loud, which could make it irritable and remove the hearing aid. Or the other reason also could be sometimes they make a mold which sits inside the ear, and if that mold is not fitting properly, it could also be a reason why the child is removing the hearing aid. Apart from this, the child can also have behavioral issues which makes them, remove the hearing aid, which have to be assessed by a developmental pediatrician, and appropriate steps taken in that regard.
Okay, so another question here is, will implants need to be changed as the child grows into adulthood? I think they mean the cochlear implant.
Yeah, that's a very good question. So what happens is these devices are very high-end devices. And when the internal device, which is implanted under the skin, is actually using only 1/4 of its technology. It's like you buy an iPhone and then you can keep on, upgrading the software for years together. So what happens is only the external processor can be changed as the company keeps coming up with newer or higher technology devices. So the internal device remains inside. They need not change it. The only reason for a change in an implant or a resurgery may be a device failure, which could be because of several reasons, like if small children have a fall and there is a bad impact on the device which causes any damage to it, then it would need a change. There is also, we tell to parents of young children who are like 1 year or 2 years, that this child may need another implant in their lifetime, which could be at any age, at 30 years, 40 years, or 50 years. Because of various reasons, either the company stops upgrading the device or the device eventually fails. Because this is a procedure which has been started just 30 years ago in the West. So it's now that we are seeing younger children who were implanted then are needing repeat implants.
Okay. And so there is also a question, Doctor, this is again to you. Then there is one question for Dr. Nadia. So this one is for you, Dr. Manasrut. Sir, is there any other option other than implantation?
So this is a very good question. Just because there is an option called implantation, it does not mean that every parent has to exercise this choice. It is important for parents to understand that whether they want their child to be in the hearing world or they want the child to learn other means of communication, which is sign language. So there are a lot of parents who wish that their child should not undergo a surgery, and this is all often when either parents or themselves have hearing loss, which is a smaller percentage, or they have somebody in the family who has got hearing loss. And then the parents can opt that, my child would learn sign language and be in the deaf world and communicate in an alternate way. So it is not necessary that the child should get implantation, but then that would be the choice which parents will have to make. The only cautionary message in this is that we still don't have that much support from the policymakers, the government, and the social system to support kids with sign language. And also, the Indian sign language is not developed. Recently, Narendra Modi, our Prime Minister, had actually announced the integration of sign language and the development of it in one of his speeches. So I think there is a lot of time for our society to develop where a child can actually continue a normal life with sign language. So parents have to be informed and then make the choice.
Dr. Nadia, there was earlier a question when you were talking about the startle action of the child, of a baby. So is this an action that happens during the waking period, or does it happen even when the baby is asleep?
All normal babies will have a startle even during sleep. If it's a loud sound, it's a response while the baby is asleep as well as in an awake state. So if there is no startle either during sleep as well as when awake, then that is a flag, red flag.
Okay.
I had another question as well, whether a baby, when should an OAE done only when the baby is sleeping?
That's
so
right.
ideally in a calm and quiet baby, you can do it. Baby is feeding, sucking at the mother's breast, or the baby is just lying down calm, should be a good situation. It's not necessary that the baby is sleeping, because sounds can interfere with the test results, and a lot of movements can interfere. Otherwise, normally lying down baby should be good.
Ma'am, I think I need any of you can take this questions. Do we have hearing specific vitamins, etc.? As is the case with that of eyes, like vitamin A? Oh, that's quite interesting. I never thought of that. Is there a vitamin supplement that can be given to children so that they do not go for hearing loss? Can it be prevented?
I'll take that. So there is no prophylactic, that is something to do to prevent a hearing loss in the form of supplements or some medications or some certain foods. But certain things that can definitely damage the ear are some toxic medications itself. So or in a prone patient, in a prone child, it's not that any person who takes this medication for a couple of days is going to get a hearing loss. So there are certain medications that can be avoided. Loud noise is toxic to the ear if it is beyond a certain level, according to WHO, 60 decibels or beyond for more than 60 minutes. So there is this loud noise for a long duration. But other than that, there is nothing that can prevent. So we can avoid things that cause hearing loss, but you cannot say that, okay, I will feed my child with this much of this a day so that the child doesn't get a hearing loss.
Right. Thank you, Dr. Nadia. Dr. Vikram, I have a question for you. I just want to know, when you say the mother is or the caregiver is the first person who actually is able to identify hearing loss, often we hear among young mothers that boys start talking later than girls. So this is there is a kind of acceptance. Is this correct or is this wrong?
Ma'am, usually this is what it is observed. But the thing is, the fact is that even before the child starts speaking, there are certain sounds that are made by the child, which usually either it is a boy or a girl. It usually happens almost at the same time. There's no much difference in that. These are called babbling sounds or monosyllables like ma, ba, da, and all that. So what you are referring to is a complete language development, or at least capability to make a sentence. That is what usually mothers say. But there's not much significant difference between the two. But yeah, we do keep hearing these things being told by the mother. What we are kind of focusing here is that the early signs of hearing loss, which is like, as pointed out earlier, like a startled reflex, or an, when a mother speaks to a child, whether the child is able to make eye contact, or if it listens to the child, the mother's sound from a other room, is it able to respond to it, or when you call a baby's name, whether its actions are changing and suddenly it hears its name. These are the things that the caretakers need to really understand to pick up early signs of hearing loss.
Okay. So here is a question, doctor. What is the difference between hearing aid and a cochlear implant? Dr. Manasmith.
Yeah, I would take that question. So it is there is a significant difference. Hearing aid is just like your speaker. So it takes the sound in, amplifies it, and gives it to the ear. And this sound is perceived by the inner ear, which is the cochlea, which converts it into electrical signals and then stimulates the hearing nerve. But what an implant does is it bypasses this entire system and directly stimulates the nerve. So the capacity of the implant is much higher than an hearing aid. Hearing aids are limited only to amplification up to around 60 decibels. After that, the clarity of the sound is not very good. So the children who are born deaf, who have got a severe loss, do not eventually develop speech. They may start speaking, but the clarity is bad. You cannot understand what they're saying. So that is the major difference between an implant and a hearing.
So I have a question, doctor. When you're talking about hearing aid and implants, suppose you implant and even then a child is not able to hear despite a hearing implant, is there something wrong with the nerves, and then that cannot be, there can be no improvement there?
So before we take up a child for an implant, we do an MRI and a CT scan for the child to identify the nerve, and then only we implant. But as you said, there are still cases who have been implanted at a young age, maybe at 1 year, and they're still 3 years or 4 years are not speaking.
Okay.
So this is a point when we have to identify other behavioral issues. Like every child not speaking does not mean has a hearing loss. So there are children who are on the autism spectrum who may have a hearing loss and still be on the autism spectrum. So if we implant, doesn't mean that the child will start speaking normally. So these days, autism and other behavioral issues can be identified early. That's why a child, before getting an implant, should have a thorough pediatric assessment to rule out other problems in a child.
Ma'am, if you permit, I just want
Yes,
to
sir.
add one small thing.
Yes, sir.
Like as Dr. Manaswat told about the cochlear implantation, the cochlear implantation surgery is not the end of it. I just want to emphasize it. It's something called as an AVT. Okay, so many times the parents or they feel that an implant, once you do an implant and the child will start hearing. That is not true. Okay, there is something called as an AVT, that is a therapy. An intensive AVT needs to be done to the child, because the moment you put an implant, it is just a sound which is reaching him. It has to be converted into a meaningful speech, meaningful language. So which takes months of this thing. So many a times, we do something called as a cochlear implant candidacy. Okay, so before that, we talk to the parents. We try to understand from where they're coming. Where is the closest place? Every place doesn't have an AVT therapist available. These are specialized people who specifically deal with these kind of children, and it's a very time consuming, it's a very laborious therapy sessions that just imagine that every week, twice or thrice, the child has to be taken to the therapist.
Yes.
And there they have to spend time, about 1 to 2 hours. So the dedication of the parents, the education status of the parents, the financial status of the parents, and most important is how motivated these parents are towards, so the real action starts after the implant. So that is the thing that I just wanted to emphasize.
So AVT is audio visual therapy. Is that how it goes? What is the expansion of AVT?
It's auditory verbal therapy.
Auditory verbal therapy.
Right. Okay. Thank you. Auditory verbal therapy. So, and sir, there is one question. Are these experimental, the devices, the cochlear implants, are they experimental devices? Meaning, do you?
No, so actually we have reached a point where implants are not experimental anymore. So they have been approved by FDA in 1985, and devices, these are very advanced devices, and these are this is one of your only sense organ which can be completely replaced if you have lost your entire hearing also. So they have crossed the stage of experiments, but there is research going on to get devices which could be totally implantable, where you can put the entire implant under the skin without anything visible outside, which is actually a major demand in our Indian population, where parents are always worried about the cosmetic issue.
Yes. And so I also had another question, sir. You implant a device. So there is a particular size in which you implant. There's a size to it. So as we grow older and older, do we need to replace this device, or is the device size enough?
So when we put the device in, the device has got an electrode at the end. So there is an extra length which is given to it, so that when the skull grows, it accommodates that growth phase, and they will not need a reimplant.
Okay, and so like I think you already mentioned this, but there is also a question on when the technology becomes, when the technology improves, would it mean that a person as they grow older would need another surgery, or?
No, they don't, because company whatever external devices they upgrade are usually compatible to the devices for at least 50-60 years. So that is the way the technology is improving. So only when a point comes where the external device has become so powerful that the internal thing doesn't accept it anymore, that is when they would need a upgrade.
Okay, so one question is, should somebody wait for the new technology? I don't think that's a smart idea, but people might have such thoughts. Should they wait until the technology improves, or?
I think for the newborns and the young children, I think there is no point in waiting, because your child would not develop speech even if you take that advanced technology after 5 or 10 years.
And here's one more question. Can implant users identify environmental noise as well as speech?
Yeah, so the current devices are pretty powerful, and with proper therapy, the child can eventually, start understanding the environmental sounds, music. There are music concerts being conducted for children who have been implanted, and they are playing the instruments. So, but these are children who have been implanted early, and that is why the age of implantation is a very important area.
Dr. Vikram, you were talking about how implants, even when you implant, you need to have audiologists and therapists who would actually help the child understand, learn a language. How important is the caretaker's role in that?
Yes, ma'am. The thing is that the AVT therapy sessions that take place in a hospital or an institute, the parents are brought to the place to understand that this is something like a class that is being taken in the school, and the homework needs to be done by the caretakers. So a good audiologist is a must, who will emphasize the next time when you come back, she or he will check whether what has been taught last time has been repeated by the parents or not, how much progress the child is making in each visit, and where is the lapse, and whether the parents are taking interest in the therapy sessions, and post therapy when they go home, whether they're doing the homework or not. So it's a very important thing that the therapy doesn't just happen in a hospital or an institute. It is a continuous process that happens, also when you go back home.
Thank you, Doctor. Dr. Nadia, I have a question for you. Ma'am, we are talking about how children, when they are born, they should be screened. Are there instances where parents actually refuse to have the child screened, or is this like mandatorily done for every child that's born in a hospital?
Yeah, so the current state is that we are trying to implement, at least in developed countries, it's a norm that all babies are screened without fail. Yes, there are parents who have concerns because they're not aware of how easy the test is and how non-invasive it is and all that. So there are parents who express their concerns regarding whether my baby will be hurt, whether it'll cause any discomfort to my baby. But otherwise, parents are more than happy to do this, because nowadays the awareness is improved, and that's what we intend by this session as well, so that parents are assured that it is simple, but it is crucial, so that we pick it up then and there and help in whatever way we can, so that the child is not left behind. So there's been tremendous improvement in the child's general development if you catch hold of them early. So that's the point.
So ma'am, I'm sorry, you were saying something?
No, that's
Okay, I have this question pertains to both you and Dr. Vikram. I have this question. How do you encourage parents to actually, when they bring their young babies, how do you encourage them to look for these signs? And have you find times, or have there been occasions when parents have said, "Oh, I didn't notice this," and when you feel that had they done it earlier, things would have been different?
Yes, many first-time parents, we've noticed that, because of lack of awareness, probably they're working. So the early cues that you actually need to look for in a child, like turning to some sounds or responding in the way of eye contact or smile, are kind of overlooked or not noticed by parents, maybe the first-time parents. So we've come across patients who have actually been brought by the age of 2 without any language development. So that's when the parent actually starts to think, okay, the child of my neighbor is doing better than my child. So isn't it time to go? So we don't want it to go till then. We want parents to pick up early, so that, like we kept repeating, we intervene early.
Okay. Dr. Vikram, I have one question for you, sir. Once the child has actually been identified as lacking in developing language development or hearing development, what will be the first path for this child after investigations? Would you directly ask them to go in for a cochlear implant, or would you say there are other paths?
See, the most important fact is that acceptance for the parents. When you tell them that there is an issue with the hearing, the acceptance takes some time. Most of them are not ready to accept this fact that there is an issue which needs to be dealt with. So we need to give them some time to understand that there is an issue. So most of them, the time they receive this, they want to cross check, they want to double check, they want to go to other doctors and confirm it, and this thing. So once you give them some time and they really understand that, okay, they go on the net, they search, and then they understand that, okay, there is a possibility that this is what happened, and they come to the conclusion that, okay, now is the time that we need to intervene. So then is when we sit with the caretakers, and then we tell them that, okay, another important thing is about the cost. The cost of cochlear implantation, it depends from various institutes to various institutes. Anywhere between 6.5 to 7 lakhs, the cost can go high. It is just the cost of the implantation. As I told you, there is, after implantation is the real hard work that starts with respect to audio verbal therapies and all that. But the thing is that even before that, like to investigate, you need a CT, MRI, DERAs, and all that. So it's a very slow process. But the most important factor that we keep telling the parents is regarding the early intervention. As pointed out early, the more you delay, the best results are achieved at the earliest intervened childs. So in US, UK, Western worlds and all, from 6 months to 1 year, most of the kids who have been detected are implanted. As you know, the system over there is different. It's all so here also, when we when we get children at whatever age as early as possible. We try and emphasize them that this is the path that needs to be taken.
Right. Thank you, Doctor. Dr. Manasmrut, I have only one last question. Is cochlear implantation, is it covered under all insurance schemes, private or government?
Very good question. Often parents come up with this question. So unfortunately, our insurance schemes do not cover for any congenital defects. That means any defects which are there by birth. So hearing loss is also a part of that. So they do not cover it. Some insurances have now started covering the cost of surgery, but it's a battle for the parents. IRDA has not yet given any guidelines on it. So parents have to, get a reimbursement or fight it out, and then they get the cost of surgery, but they would not be reimbursed for the device. There are government schemes running in almost like most of the states in the country now, and there is a national scheme which is run by the government of India. It's called the ADIP scheme. All these schemes have got certain criteria for the age limit and the financial status of the parents to enroll them, and so that the child gets an implant.
Okay. Thank you, Doctor. Thank you very much, all of you, for taking time off on a Christmas Day and spending time here. This wellness series has been really wonderful, and you answered quite a lot of questions. Thank you to all of you.
Thank you.